much. So thank you for the invitation. I present you the HypoECMO, a trial assessing the effect of hypothermia on mortality on cardiogenic shock patients rescued by VA ECMO. So my conflict of interest. To begin, a bit of pathophysiology. This is a classical figure of the old and new paradigm in cardiogenic shock. The old paradigm is explained by the mechanical cardiac dysfunction centered on the low cardiac output, on the congestion, leading to ischemia and increase in cardiac dysfunction. With the new paradigm, there is a central place for inflammation with a massive release of NO and cytokines, leading to vasoplegia and a decrease in cardiac contractility. In fact, cardiogenic shock is not only a mechanical cardiac disease, but also an inflammatory disease, a bit like septic shock. I'm an intensivist. So this is a new definition of cardiogenic shock, stratified with 5 stages, from A to E. A, at risk. B, beginning, the baby cardiogenic shock. C, classical cardiogenic shock, deteriorating or refractory cardiogenic shock. And E, extremis, most often refractory cardiac arrest. And in line with this stratification, you have an increase in the inflammation. And from stage C, you have organ failure, mainly kidney and liver failure, which are prognostic in cardiogenic shock rescued by VA ECMO. So, of utmost importance, you have to initiate ECMO before the onset of this new organ failure, kidney and liver, from stage C sometimes, but most often when you have a refractory cardiogenic shock or in case of refractory cardiac arrest. Our group tested hypothermia in refractory cardiogenic shock under ECMO in an experimental pig model of STEMI cardiogenic shock in refractory state, rescued by VA ECMO. Recreate the cardiogenic shock by ligation of the left ascendant artery. Animals were randomized in the hypothermia group or the normothermia group, 12 animals only, and we maintained the experimentation for 8 hours. The main results were that the total amount of vasopressor infused were lower in the hypothermia group compared to the normothermia group, and that the vascular responsiveness to vasopressor was increased in the hypothermia group compared to the normothermia group. Thus, our hypothesis was that early moderate hypothermia compared to strict normothermia may improve mortality in patients with cardiogenic shock receiving VA ECMO. ECMO was a multi-center randomized controlled trial with 20 centers in France only. Inclusion criteria were very simple: intubated cardiogenic shock treated with ECMO. And non-inclusion criteria were refractory cardiac arrest. They were too severe. ECMO for LVAD, or heart transplantation, and uncontrolled bleeding. The coordinator was Bruno Levy, the study design, patients have to be included within the 6 hours after ECMO initiation, and the temperature was managed by the heat exchanger in the device during 24 hours with a progressive reheating period for 48 hours. But it is important to remember that in the normothermia group, the temperature was also controlled by the heat exchanger, so no fever. Endpoints, for the primary endpoints, it was 30 days mortality, and just remember these secondary endpoints: composite endpoint of death, cardiac graft, stroke, or escalation to LVAD at day 30. The sample size was a bit optimistic, maybe, because the anticipated mortality in the control group was 50% and 35% in the intervention group, with a relative risk reduction of 30%. So the anticipated sample size was 334 patients. The flowchart was very classical. Just look that 124 patients were non-intubated and thus non-included. This is a very huge part of patients under VA ECMO. Temperature curves fitted well with a huge difference between the two groups with no overlap between hypothermia group and normothermia group. And characteristics at inclusion were very classic for a refractory cardiogenic shock population, mainly male, with prior to inclusion a cardiac arrest in 48%, and the first etiology was obviously acute coronary syndrome, and more than 80% of the population received vasopressors. This is a primary endpoint, a bit disappointing because the result is neutral, with no difference between the two groups, but 42% rate of mortality in the hypothermia group compared to 52% in the normothermia group. This is the secondary endpoints. Interesting because at D13, disease, cardiac graft, LVAD, and stroke were slightly lower in the hypothermia group compared to the normothermia group. And this is important, there is no safety issue except for the number of transfusion a bit superior in the hypothermia group. In conclusion, early application of moderate hypothermia for 24 hours does not increase survival compared with strict normothermia. But regarding the curves, the composite endpoints at 30 days was lower in the hypothermia group, but it is only a secondary outcome and there is no safety issue. Thank you very much for your attention.
Thank you, Antoine. Nice presentation. Just a question, because you have said that it's 10 hospitals in France involved?
20.
20. How long it took to recruit 300 patients on ECMO?
Extremely fast.
Extremely fast?
Extremely fast.
Wow.
Only two years and a half only.
Okay, you are using a lot of ECMO, I see.
And we cannot say where, but the paper is submitted in a big journal.
For a long time.
It's good. Okay, Salvatore.
Congratulations, really good job. Just one question. I know that was not the primary endpoint of the study, but as you know, we delivered an important score for cardiogenic shock into the GREAT network. That was from Veli-Pekka Ariola. Did you have any data is it a great opportunity to check the value of our score in these patients to see which patients is going to be treated or not? This is something that is having this big population is really an opportunity. I don't know if you had already the idea to do or you are going to do it.
It is not planned, but yes, I know very well the CardShock database. I don't know the patient who will benefit the best of the hypothermia. Maybe those with renal, just the beginning of the renal and the liver dysfunction. That's our hypothesis, but this is not sure. There is no difference between the different subgroups because we included a very large population. I mean, it went fast, okay, but we included acute myocardial infarction, chronic dilated cardiomyopathy, myocarditis, and so on. So yes, maybe they are not exactly they are not exactly the same disease. So yes, we have to do this work, but it will be a next level. Many questions.
Frank in Italian.
Okay, in Italian? See. So nice job and a good sized paper. Usually when you have a negative outcome, there's a power associated with it, and I expect since you put this to a fancy journal, you know the power. What was the power?
The power of the study?
Yeah.
80.
80, okay.
80%. But yes, 30 relative risk reduction, it was a bit optimistic, obviously. But we calculated with that, with only 50 to 70 other patients included, it would have been significant. But that's the game.
Yeah, because they fell short at the end. I mean, 0.07, it was okay. Okay, we need now to move on. Thank you so much. Thank you.